Hello, graduating class of 2018. My name is Nathan Watts, and today I'll be analyzing a right lateral hand radiograph that I did on September 18, 2017 on a 63-year-old female patient that was complaining of chronic pain in her right hand. The patient has a history of inflammatory polyarthropathy, and this visit was to evaluate any ongoing complications that she might be having. The patient stated that the pain has been increasing over the past couple weeks, and the doctor ordered a series of x-rays to evaluate the area of interest. As far as the identification of procedures and the projection, for my analysis, I took a lateral medial projection of the right hand with the Shimatsu digital radiograph machine. Before I brought the patient back to the exam room, I set it up. I verified all of her procedures that needed to get done, and then when I was confident that I was ready to receive my patient, I went up to the front. I identified her by her last name, went and met with her, checked her wristband, brought her back, and then I identified her two forms of identification: her full first and last name and her date of birth. I introduced myself, of course, and once I had her take all of her jewelry off from her hands, I brought her into the room and I explained the procedure that we were going to be doing. Right hand series of x-rays, so there's going to be 3 x-rays, and one of them was, of course, the lateral. Using a 40-inch SID, I had the table at an adequate height for her to place her forearm flat on the table, resting, and I placed the patient's hand in a lateral position with her fingers fanned and the CR entering the base of the second metacarpal. I placed my right lead marker on the lateral side of the patient's right hand and collimated my light field so that it was about an inch bordering the soft tissue. I instructed her to hold very still, and using a 62 kVp at 1 mass, I exposed my patient. The exposure indicator number was 308, which is just outside of Aston Radiology departmental procedures, and we'll get into that when I talk about some of the errors that I made. As far as the image criteria, according to Martenison in 2015, the following image guidelines are required for an optimal lateral hand projection. The 2nd through 5th metacarpals are superimposed. 2nd through 5th digits are separated, visualizing little superimposition of the proximal bony and soft tissue anatomy. Thumb is visualized without superimposition of the other digits and in a slight PA to PA oblique position. IP joints are open, phalanges are not foreshortened. Thumb is close to the hand, MCP joints are at the center of the exposure field, phalanges, MCs, carpals, and 1 inch of the radial or the distal radius and ulna are included within the exposure. The facility's identification requirements are visible. The technologist's lead marker is visible and positioned laterally to the extremity with no superimposition over the VOI. Proper radiation protection and shielding was used appropriately, and there was no quantum noise and or other types of artifacts present, and the correct SID is used. Additionally, Martenison states that the following position procedures should be performed to obtain an accurate lateral hand projection. Position the medial aspect of the hand against the IR, adjust the hand rotation to ensure the 2nd through 5th knuckles are placed directly over one another in a true lateral position. Center the hand on the IR, making sure the CR is centering at the base of the 2nd metacarpal. Fan the 2nd and 3rd digits anteriorly and the 4th and 5th digits posteriorly. Support the hand and fingers as needed to maintain positioning. Position thumb close to the hand and open the collimation appropriately. For my image analysis of this lateral right hand radiograph, the hand was centered on the IR and the CR was centered at the second and metacarpal phalangeal joint, MCP, using a perpendicular beam. The second and third digits are fanned anteriorly. The fourth digit is more in line with the rest of the wrist and forearm, and the fifth metacarpal is fanned posteriorly. The second through fourth metacarpals are superimposed, with the fifth metacarpal slightly rotated anterior due to excessive external rotation. My longitudinal collimation is open to show the distal phalanges and about 1.5 inches of the distal forearm, and my transverse collimation is open to 1.5, maybe even 2 inches of the soft tissue of the thumb. According to Bontrager in 2014, lateral hand x-ray should be taken at 65 to 70 kVp, and mine was at 62 kVp in 1 mass. The image was anonymized for the purpose of this presentation and for my paper, so that no patient identifiers were present, because if there were patient identifiers present, such as birth date, social security number, MRN, full name, that would be in violation of HIPAA, which stands for the Health Insurance Portability Act, Portability and Accountability Act of 1996. As we get into my errors that I'll point out once I show you guys the radiograph, the biggest one is the fifth metacarpal head was not superimposed with the other metacarpal heads, and this was again due to excessive internal rotation. So the thumb was rotated more laterally to the rest of the hand. And it was due to the fact that I was focused on the wrist as opposed to the knuckles, which is the correct way, according to Martenison, that I should have been focused on positioning my hand to maintain that true lateral position. Again, some of the smaller issues that I had was with collimation. I had it open a little too much, and I could have probably closed in my transverse collimation a little bit more, and that probably would have helped with my exposure index number. Again, the departmental exposure number index for extremities is between 100 and 300, and I was just outside that range at 308. As far as the doctor's impression for the radiograph goes, there were no erosions visible, and there were osteoarthritic changes in the distal IP joint of the second digit and the CMC of the first digit, and more mildly in the third and fifth digits. On the third digit, there is a small spur at the metacarpal head annotated with an asterisk in the picture, which I will show you. And in conclusion, Martenison 2015 states that an optimal lateral hand radiograph must include a second through fifth metacarpal, second through fifth metacarpals are superimposed, second through fifth digits are separated, visualizing little superimpositions of the proximal bony or soft tissue anatomy. Thumb is visualized without superimposition of the other digits and is in a slight PA to PA oblique position. IP joints are open, phalanges are not foreshortened, the thumb is close to the hand, MCP joints are at the center of the exposure field, phalanges, MCs, carpals, and 1 inch of the distal radius and ulna are included within the exposure field, and technologist lead marker is visible and positioned laterally to the extremity in question. According to the standards, this lateral hand radiograph has a couple of errors present, and I've gone over the steps that can be taken to ensure that the errors here have been avoided. Finally, I'm going to show you guys my radiograph. If you can see right here, I know it's hard to see. At the top, we have the distal phalange of the fourth digit. We have the distal interphalangeal joint, or IP joint, middle phalange, proximal IP joint, proximal phalange. In this area would be the superimposition of the MCP joints. And as you can see here, due to the slight external rotation, the fifth metacarpal is slightly internal or anterior to the rest of the MC metacarpals. And here we have the carpal bones, and down here we have the ulna and radius superimposed. As I said, annotated with the asterisk is from right here on this line right here. There's a small spur, which I'll try to get in close enough. You might be able to see that spur, but there's a spur. Thank you for your time, and if anyone has any questions, feel free to ask them at this time. If not, thank you so much for your time, and that was my presentation.